topic given to me today is genitourinary syndrome of menopause. It itches so much there, especially in night. I take anti-allergic and keep ice pack at perineum. I don't know when shall I pass through it. Or I scream when I pass urine, but the culture is always sterile. Or down there, it always hurts. I want to have a satisfying sex life, but I tense up anytime my partner comes near that area. After menopause, I have pain. I have been told to just relax and do it more often, but it's not getting any better, and I totally avoid sex now. Or I leak before reaching bathroom. I need to pass urine every half an hour. I have stopped going to mall. I leak when I have a seasonal cough. Even use diapers. Sometimes I leak while being intimate. It's very ungraceful. Can't live with it. These are the normal complaints that postmenopausal women come to us when they present with GSM. Now, recessive condition caused by estrogen deficiency in menopause and is an inevitable process. The term genitourinary syndrome of menopause replaces the older term vulvovaginal atrophy to reflect the broad spectrum of symptoms affecting both the genital and urinary symptoms. It significantly impacts sexual health and eventually the quality of life. The prevalence of GSM is 40 to 50% in postmenopausal women. Only 25% seek medical attention due to lack of awareness and cultural stigma. The prevalence of urogenital symptoms in postmenopausal women in a study conducted by IMS was 15%. The declining levels of estrogen in menopause leads to decreased vaginal ectobacilli, increased pH, altered epithelial morphology, reduced vascular flow, and reduced fluid secretion in vagina, leading to GSM. Now, how to document GSM? The description of symptoms is important, effect on quality of life is important, sexual history and previous interventions history is important. A woman whose symptoms do not always correlate with physical findings. For example, a woman who is not sexually active may have few symptoms despite signs of advanced genitourinary atrophy on examination. In contrast, a woman with an active sexual life may complain of dryness and discomfort with intercourse, whereas the pelvic examination suggests only mild atrophy. Thus, both history and examination are essential to make a correct diagnosis. So symptoms can be classified into genital, that is vaginal dryness, irritation, burning, increased risk of infection, sexual, dyspareunia, reduced arousal, reduced lubrication, and decreased sexual satisfaction, urinary, urgency, frequency, dysuria, recurrent UTIs, and incontinence, and pelvic, that is sensation of pressure, vaginal bulging, difficulty emptying bladder or bowels, discomfort during sex, but patient feels better after orgasm. Now, what is the differential diagnosis for GSM? First is lichen sclerosis. We know that lichen causes intense itching, white plaques, and scarring, while VVA presents with dryness and dyspareunia without scarring. Diagnosis is by toluidine blue test, and treatment involves corticosteroids. Lichen planus, it often affects more than one part of the body. Many patients with oral manifestations also have genital involvement. Vulvar symptoms include pain, burning, and scarring. Diagnosis is by biopsy and treatment is corticosteroids. Vaginal infections are associated with discharge and odor and elevated pH. Diagnosis involves identifying specific pathogens and treatment is antimicrobial agents. Vulvodynia, it presents with vulvar pain without any identifiable cause that persists for at least 3 months. Pressure point testing, that is using a cotton swab in circumferential fashion along the vulvar vestibule, will elicit pain even with light touch. Treatment includes vulvar hygiene, stress reduction, pelvic floor physical therapy, and psychological intervention. Now, how to dissect? So a detailed medical and sexual history is essential. Do ask key questions that do you experience vaginal dryness or irritation? Is intercourse painful? Is the desire for intercourse decreased? Or do you frequently suffer from urinary infections? On examination, there is loss of rugae and pale, thin vaginal epithelium, tenderness on palpation, reduced vaginal elasticity, vaginal narrowing, and an increased susceptibility, trauma, and irritation Epithelial tissues are friable and submucosal petechiae hemorrhages may be seen, that is senile vaginitis. So the lab tests suggest that the vaginal pH has crossed 5, vaginal maturation index is measured, vaginal health index is measured. You do a urine analysis and urine culture to rule out infection. Now in vaginal health index, we look for overall elasticity, fluid secretion type and consistency, pH, epithelial mucosa, and moisture. And we grade the patient as per the vaginal maturation index. The goal is symptom relief and restoration of vaginal health, combines lifestyle, non-hormonal and hormonal therapies, tailored based on severity, comorbidities, and patient preferences. Now, first and the foremost thing is that regular sexual activity improves blood flow and elasticity, so it should be continued till the end. Vaginal moisturizers maintain hydration and pH balance. Lubricants help during intercourse. Pelvic floor exercises strengthen the support structures, and pelvic physiotherapy can assist with the bladder symptoms. So the goal of use of vaginal moisturizer and lubricants is to reduce daily symptoms of GSM and to facilitate sexual activity. Vaginal moisturizers are intended for use routinely, typically 2 or 3 activity. These products are typically bioadhesives. The lubricants like KY jelly, silicone-based jellies, they are used only at the time of sexual intercourse. Despite moisturizers and lubricants, patient still has dyspareunia. Now we move on to the next treatment, that is the hormonal treatment. The treatment options are local estrogen therapy, which is most viable, available as creams, tablets, or rings. It improves vaginal elasticity, lubrication, and urinary symptoms. The systemic hormone therapy is to be given to patients who have GSM associated with vasomotor symptoms also. So in such patients, we use transdermal or oral HT, and selective estrogen receptor modulators like ospemifene are also being used. It is a 60 milligram tablet to be taken daily for vulval health. It is not recommended in women with known or suspected breast cancer. So these are the local estrogen creams which are available. First is the conjugated estrogen, that is Premarin, available is 0.6 to 5 milligram per gram of cream. 17 beta estradiol, that is estrase, then Evolon, which is estriol, vaginal tablets, which are Mvexi, Vegifam, and Uvafam, to be inserted daily. Vaginal ring, 2 milligram ring, which is to be inserted every 90 days. As far as creams are concerned, they are to be applied daily for 21 days, then stop 7 days and apply 0.5 milligram intravaginally twice per week. It can be continued for long days till the patient is completely relieved. So you will ask me about the safety of these estrogens. I said you use it as long as possible. The local estrogen therapy is favorable because the estrogen levels reached in body are significantly lower. The risk of thromboembolism is not increased. Large observational studies evaluating longer exposures to vaginal ET identified no increased risk of endometrial cancer, and use of vaginal estrogen was not found to be associated with increased risk of breast cancer too. Improvement in GSM typically occurs within few weeks of starting the therapy. However, treatment for 12 weeks may be needed for maximum benefit. In absence of contraindications, therapy should be continued as long as needed for management, as symptoms may recur on discontinuation. Clinical trial safety data are limited to 1 year, but observational studies demonstrate safety with long-term use even for more than 2 years. Based on available limited safety data, use of progesterone or routine endometrial surveillance is not recommended in low-risk women using low-dose vaginal estrogen therapy. Any spotting or bleeding requires a thorough evaluation that may include transvaginal ultrasound or endometrial biopsy. The pre-treatment investigation, usually we require only a pap smear and transvaginal sonography before starting the emerging therapies are intravaginal DHEA, which is available in the name of Prastrone, 6.5 milligram vaginal suppository daily, which stimulates estrogen and androgen receptors. improving the vaginal health. And more recently, laser therapy, that is carbon dioxide or YAG laser, is being used to rejuvenate vaginal tissues, though it is not FDA approved. So progesterone and ospemifene is a drug which is available in the form of 60 milligram tablet. It improves vasomotor symptoms, vaginal pH, dyspareunia, vaginal dryness, and genital examination findings. It is shown to reduce the risk of recurrent UTIs also, but it should not be used in patients who have had previous history of breast cancer. The energy-based devices, as I have told you, are now being frequently used. They are not FDA approved, but they are still under investigation, but some people say that they give rewarding results. Now, some similar situations in patients with venous thromboembolism, you can use local estrogen. In patients on aromatase inhibitors for breast cancer, you can use local estrogens. Then in breast cancer survivors, you should prefer moisturizers, lubricants, and pelvic floor exercises. You should prefer topical lignocaine, low-dose estrogen therapy, vaginal DHA, or energy-based devices. But if the patient is not relieved, then the current 2025 paper suggests that the use of vaginal estrogen in patients with a history of breast cancer does not appear to be associated with an increased risk of breast cancer recurrence, breast-specific mortality, or overall mortality. So it should be used in the interest of the patient. In cervical cancer survivors, local or systemic HRT is safe. Now, in patients with endometrial cancer, the available retrospective and observational studies fail to show an increase in risk of recurrence or death, so it can be used. But in patients who have had stage 3 or 4 endometrial cancer, women with type 2 tumors, no definitive studies exist. So in such patients, HRT is not recommended. In ovarian cancer survivors, HRT can be used. Local estrogens can be used in such patients. Consider HRT if she's symptomatic. There is no increased risk of recurrence or death in women opting HT after treatment of ovarian cancer. This is as per NAMS 2017. Now, something about urinary incontinence. We all know 4 types of incontinence, that is stress, urge, mixed, overflow, and functional incontinence. In stress urinary incontinence, prefer Kegels exercises, duloxetine, or mid-urethral slings. In urge incontinence, lifestyle intervention, behavioral therapy, physical therapy, drug therapy, that is oxybutylin or desmopressin is to be used. Even botulinum toxoid is also being used these days. Then in overflow incontinence, you need to catheterize the patient and a surgical correction needs to be done. Kegels exercises are always recommended in elderly women. You must repeat 10 to 15 Kegels per session, and you should do it at least 3 times a day. Emsella chair is not available, which passively causes the Kegels exercises, and it is a useful tool, but the studies have yet not come on its success. Bladder training is to be used in patients with urge incontinence. Gradually, the interval between the passage of urine is to be increased. Patient should be told to maintain a bladder diary. So, even in urge incontinence, the use of local vaginal estriol cream is now being recommended, and urethral dilatation is also helpful in these patients. Female sexual dysfunction associated with GSM is a topic in which I would request the forum to have a separate talk. I can give that talk whenever you wish to, and we can discuss it in that. So GSM is a common yet often overlooked condition that significantly affects postmenopausal women's health and quality of life. Early diagnosis and appropriate treatment can effectively manage symptoms. Raising awareness and encouraging open discussions can help more women seek timely medical support. So think positive. Positivity breeds positivity. Thank you very much.